Hi guys, this is Nikki Bruce. We're in Nursing 2 and I have a presentation here for Clostridium Difficile. Originally I had this beautiful PowerPoint set up with voiceovers and I ran into a lot of troubleshooting errors trying to get this converted to YouTube. So unfortunately I'm going to have to broadcast this from my phone. I'm hoping you get a pretty good quality picture. If not, shoot me an email. I can send you the outline for this presentation. So let's get started. Alright, this picture says life was so much simpler before I had ever heard the word C. diff, and that is very, very true. The pathophysiology. It is a bacterial invasion of the alimentary canal. It produces toxic substances. The mucosal cells respond by secreting H2O and electrolytes. Fluid excretion exceeds absorption, causing imbalance. This is a very highly infectious diarrhea. It's mostly seen in immunosuppressed hospital and nursing home patients and patients that are on a long-term antibiotic therapy, which causes destruction of normal flora. It is an antibiotic-associated pseudomembranous colitis, AAPMC. Alright, C. diff spores can survive up to 70 days on inanimate objects, such as commodes, telephones, thermometers, bedside tables, floors, and hands of healthcare workers. It's easily transmitted from patient to patient from lack of hand hygiene. Soap and water are what we use to get this off our hands. Antiseptic hand rub does not work. Most common transmission through the mouth, so fecal oral transmission. Yuck. It produces two toxins under the right conditions. Toxins A and B. They cause tissue damage seen in AAPMC. It's frequently associated with antibiotics such as lincomycin, clindamycin, ampicillin, erythromycin, tetracycline, cephalosporins, and aminoglycosides. A 2015 CDC study found that almost 500,000 infections in the U.S. in a single year was caused by C. diff, and 29,000 deaths directly attributable to C. diff in 2011 within 30 days. It's the most common cause of healthcare-related infections in the U.S. An estimated $4.8 billion in excess healthcare costs in acute care facilities alone. Also in 2011, 83,000 patients had at least one reoccurrence. Okay, and that's an image of what C. diff looks like under the microscope. It is not a pretty sight. Okay, and this is just a cute little cartoon of C. diff attacking the normal flora. Sorry, guys. Signs and symptoms. Obviously, diarrhea. High water content in this diarrhea. It's very, very liquidy. You're possibly also going to find blood and mucus if it involves the intestinal mucosa. Patients are going to complain of rectal urgency. And this pretty little word I'm hoping I don't butcher is tenesmus. It's an ineffective and painful straining with defecation. Also nausea, abdominal cramping, fever, and vomiting. Alright, that is a picture of the inside of someone's intestine with C. diff. Obviously there's a lot of inflammation going on there. I'm not sure if you can see the redness so well, but there's a lot of really red mucusy, almost like bleeding going on. Diagnosis is through a sigmoidoscopic or colonoscopic examination. A stool specimen containing blood, mucus, or white blood cells. There's also a CD test to check for antigens. Toxins are found in 1 to 2% of normal populations, 10% of hospital inpatients, and 85 to 90% in patients with proven AAPMC. However, the test alone is not conclusive, but it aids in diagnosis. Negative test does not rule out C. diff associative colitis, so remember that. Treatment. Mild cases of antibiotic-related C. diff include discontinuing antibiotic therapy and getting them on fluid and electrolyte replacement. In severe cases, we're going to discontinue antibiotic therapy and initiate antimicrobial therapy. The drug of choice is metronidazole. If not, then vancomycin. Also, IV fluid and electrolyte replacement. As far as antidiarrheal and antispasmodic medication go, it's not typically used because it may increase the severity of infection. Your body is essentially trying to rid itself of infection. So if we give them something that's gonna make them not go, then it's just gonna prolong the infection basically. There's also a new treatment they're working on called fecal microbial replacement. The PT is prepped for a colonoscopy. A fecal sample is taken from a donor and sent to the lab, and that sample is placed in the patient's sigmoid colon. The goal of this therapy is to promote growth of normal flora. It has a success rate of greater than 90%. However, it is not approved by the U.S. Food and Drug Administration yet. Okay, here are some of our nursing interventions. We're going to do an assessment to aid the physician in determining the severity of the infection, the onset, number of people exposed, and determine if this is going to be a community health issue or not. We're going to assess for fluid imbalance, postural change in blood pressure, skin turgor, mucous membrane, and urinary output. Also, we're going to throw in their daily weights. As far as skin turgor goes, try to remember that with our geriatric population, we're going to check their skin turgor on their chest, not on the back of the hand like we do with some of the younger folk. If they can tolerate anything oral, you're going to start them out on clear liquids like apple juice, clear carbonated beverages, clear broth, plain gelatin water, and especially Pedialyte. As far as the apple juice goes, I'm not really sure about that, but that is something the book suggested, so I did throw that in there. If they're on IV feedings, we want to maintain intravascular volume and maintain intake and output. Again, daily weights. We're going to provide meticulous pericare and hygiene. Apply barrier cream, briefs, and put that bedside commode as close to the bed as possible. So, well, obviously they don't have to go as far to use the restroom. We're going to do frequent skin assessments, check for any kind of skin breakdown. We're going to instruct the PT to report number, color, and consistency of each bowel movement, and to report any abdominal cramping and pain. Instruct the patient and family on the importance of hand hygiene and contact precautions. If you see a family member walking into this person's room and they're not putting on gloves or a gown, go ahead and provide that kind of education to them, because they could easily take that home to a family member or catch that themselves. Also, cleaning with bleach is recommended. If this patient was at home and then came back to the hospital with these symptoms and was diagnosed, the best thing for their family to do is clean as many surfaces as they can with bleach. We're also going to monitor labs, white blood cell with differential, CBC, light, specific gravity. And this is something that I got from the CDC website. It is prevention steps. We've got steps such as careful prescribing and use of antibiotics, early and reliable diagnosis, immediate isolation of infected patients, contact precautions, wearing gloves and gowns for all contact with patient and environment, adequate cleaning of the patient care environment with EPA registered disinfectants, and effective communication when C. diff patients are transferred between healthcare facilities. Prognosis. It's better when diagnosed early and antibiotics are changed. This allows normal intestinal bacterial growth to resume. And it also depends on the patient's overall condition. What did they have before this? How healthy are they? How old are they? Okay. This came from the Peggy Lillis Foundation. I can also provide these pictures if you guys would like them. It says the hidden truth about C. diff infection, and I found this extremely interesting. American deaths from C. diff infections outpaced HIV/AIDS and drunk driving combined. Wow. On an average, CDI increases hospital stay by 3.3 days. 17,000 children get affected with C. diff, and approximately 500,000 C. diff infections happen annually. It is the 17th leading cause of death in people 65 and older. 9,000 nursing home deaths per year and reoccurs in 1 out of 5 patients. It costs an annual $8.2 billion in hospital costs. And C. diff stays are 3 times the cost of many other stays, such as pneumonia, acute MI, CHF. Okay, I've got some sources here. I will provide these on the discussion panel in case you want to go back and look. The first one is about fecal microbial transplantation. It's a YouTube link. Really interesting to watch. I've got a link to the CDC website that kind of gives a little bit more information about C. diff, and it also has several other infections you can look at. This last one is an article called The Burden of C. diff. It contains a lot of statistics that I pulled off there to show you guys just the major big picture of C. diff and how serious it is. Now, the main thing I want you guys to take away from this is hand washing. Soap and water, not any of that antiseptic hand soap. I know that in the healthcare system we tend to get in a hurry and we want to use that antiseptic hand rub rather than taking the time to wash our hands. But you have to remember that that antiseptic hand rub is not going to kill C. diff. So especially if you're dealing with anyone with any kind of GI symptoms, or you're dealing with a C. diff patient, you have to wash your hands with soap and water. This is the most easily preventable disease in the healthcare, yet it's one that you see the most occurring in the hospitals, and really there's no excuse for it. So always wash your hands with soap and water. That's the most important thing that you can do for yourself and for your patients to prevent this from happening. Also, thank you so much. If you have any questions, let me know. And again, if you would like this outline, shoot me an email. I'll be more than happy to send it to you. Thank you, guys.